The definition of, at first I'm going to start about the definition of osteoporosis. So osteoporosis is a systemic skeletal disorder characterized by decreased bone marrow, uh, deterioration of bone tissue, microarchitecture resulting in increased bone fragility, higher risk of fractures, and particularly in hip, spine, and wrist. It is commonly affect postmenopausal women due to the decline in estrogen level plays a crucial role in bone remodeling. So according to the World Health Organization, osteoporosis is defined as mineral density that is 2.5 standard deviations or more below the mean mass of a young healthy adult as measured by dual energy X-ray absorptiometry corresponding to a T score of less than less or equal to 2.5. Excuse me. Complete slide two. Excuse me. Complete slide two. So, so here, my previous speaker, Silima, has mentioned nicely about the metabolic changes of postmenopausal women. She has mentioned details about diabetes mellitus in postmenopausal women. And now the classification of osteoporosis again we divided into two types. One is primary osteoporosis and another is secondary osteoporosis. The primary osteoporosis again divided into postmenopausal osteoporosis and senile and age-related osteoporosis. So why postmenopausal women are at risk? The postmenopausal women are at significantly increased risk of developing osteoporosis, primarily due to the decline in estrogen levels that occurs after menopause. Normal estrogen levels in premenopausal women typically ranges from 30 to 400 picogram per ml. So in postmenopausal women, it becomes E2 is usually 15 picogram per ml and E1 is the level between 7 to 40 picogram per ml. So estrogen is essential for maintaining the bone density as it inhibits bone resorption by osteoclast. After menopause, the sudden drop in estrogen accelerates bone turnover. Additionally, postmenopausal women may experience age-related calcium and vitamin D deficiencies, reduced physical activity, and other comorbid conditions that further contribute to bone loss. These combinations of hormonal, nutritional, and lifestyle factors significantly increases the risk of fragility fractures in this population. So the postmenopausal osteoporosis is very important in osteopathy in our country. So here in basically in developing countries. So epidemiology and global burden, osteoporosis is a significant global issue, especially among postmenopausal women, affecting over 200 million worldwide. So about 1 in 3 women over 50 will suffer osteoporotic fractures, commonly at the hip, femur fracture, spine, or rib joint. In India, postmenopausal women may lose up to 2% of bone mass annually, leading to high rate of osteoporosis and osteopenia. Here, as population age, the incidence of fractures, particularly hip fracture, continues to rise, bringing increased morbidity, mortality, and healthcare cost. By 2050, hip fractures are projected to rise by 310 310% in men and 240% in women, with the greatest increase in Asia. So this highlights the urgent need for prevention, diagnostic, and management strategy. So this is very important for women health in postmenopausal women health. So Indian epidemic osteoporosis is a growing public health concern in India, particularly among postmenopausal women. It is estimated that a large proportion of Indian women over 50 suffer from low bone mass, with studies indicating an annual bone loss of up to 2% after menopause. Here, this contributes usually the postmenopausal woman contributes to a high prevalence of contributes these factors contributes to a high prevalence of osteoporosis and osteopenia among the population of postmenopausal women. Common fracture site include the hip. I have already mentioned about hip, spine, and wrist, often leading to disability and loss of independence. So, with India's aging population, the burden of osteoporotic fractures is expected to rise sharply nowadays. There is an urgent need for awareness, early diagnosis, and effective management strategies tailored to the Indian population. Here, what about the pathophysiology of postmenopausal women? The role of estrogen deficiencies are mainly my previous speaker has already said about the estrogen deficiency. Mainly the osteoporosis is mainly due to the estrogen deficiency in postmenopausal occurs due to estrogen deficiency. So estrogen is a vital for bone health as it inhibits osteoclast activity and maintains bone remodeling balance. So after menopause, estrogen levels drop sharply, leading to increased bone resorption and reduced bone density. This hormonal deficiency is the main cause of osteoporosis in postmenopausal women. Bone remodeling becomes imbalanced with resorption in postmenopausal women, especially in femur region fracture. So here there were several factors. Cell of osteoporosis. I have already. There is a precursor, the estrogen, osteoclast precursors. Now, the risk factors for postmenopausal women, there are two categories mainly divided into two categories. One is non-modifiable and another is modifiable factors. The non-modifiable factors like risk factors increasing age, especially more than 50 years, and female sex, particularly postmenopausal women, there is a predisposed of family history of osteoporosis or fragile fractures. Caucasians and Asians ethnicities are more susceptible to osteoporosis in early menopause, natural or surgical before 45 years, low peak bone mass acid during young adulthood. So there are some modifiable factors like calcium and vitamin D deficiency, physical inactivity or sedentary lifestyle, smoking, excessive alcohol consumption, low body weight or low mass index, and use of certain medications like corticosteroids, taking corticosteroids due to other diseases like autoimmune diseases, SLE, rheumatoid arthritis, etc. Anticonvulsants like phenytoin, so PPI. So use of certain medications may lead to early osteoporosis in early osteoporosis. So clinical features, what about the clinical features of osteoporosis here? That there are several signs and symptoms of osteoporosis. Osteoporosis is often referred to as a silent disease because it typically progresses without noticeable symptoms until a fracture occurs. In the earliest stages, most individuals are asymptomatic. As bone loss advances, some common signs and symptoms may begin to appear. The most frequent and often the first clinical manifestation is a fragility fracture, typically involving hip, spine, or wrist, which occurs with minimal trauma. Vertebral fractures may occur, can lead to loss of height, stroke posture, which is called kyphosis or Dogar's hump, and chronic back pain due to collapsed vertebra. So in some cases, in some cases individuals may experience bone pain or tenderness, particularly in the spine and or hips. Fractures may occur with normal daily activities such as bending, lifting, even sometimes it may occur even coughing. So it is very dangerous. So these complications can significantly impair mobility, independence, and overall quality of life, especially in elderly postmenopausal women. So diagnosis, osteoporosis diagnostic relies on bone mineral density assessment and fracture risk estimation. Here, there are several tests. The DEXA scan is the gold standard for measuring bone mineral density at the hip and spine with T score less or equal to minus 2.5 indicating osteoporosis and minus 1.0 to minus 2.5 suggesting osteopenia. The FRAX score developed by WHO World Health Organization estimate a 10-year fracture risk based on clinical factors such as age, BMI and smoking and prior fractures. It can be used with or without BMD and help guide treatment, especially in osteopenic patients. Together, DEXA and FACS offer a comprehensive evaluation. There are four criteria for osteoporosis. The World Health Organization classifies osteoporosis based on the T score derived from the DEXA scan. Normal T score more or equal to minus 1.0. Osteopenia, low bone mass. A T score between minus 1.0 and 2 or minus 2.5. Osteoporosis T score more than less or equal to minus 2.5. Severe cases, established cases that T score less or equal to minus 2.5 with one or more fragility fractures. So there are some management modalities of postmenopausal osteoporosis here. Non-pharmacological therapy and management. There are two types of management. One is non-pharmacological therapy and another is pharmacological therapy. In pharmacological therapy, usually we include hormonal replacement therapy, anti-resorptive agents, and anabolic agents. So non-pharmacological therapy, mainly the lifestyle modification is necessary. So lifestyle intervention, proper nutrition is key to preventing osteoporosis in postmenopausal women. Here, the daily intake of what 1,200 milligram calcium and 800 to 1,000 international unit vitamin D support bone health and reduce fracture risks. The protein here 1.0 to 1.2 gram per kg per day is bone matrix formation, while micronutrients like magnesium, zinc, and vitamin K support bone metabolism. So vitamin D must be present before absorption of calcium. So vitamin D is very important for uh, prevent osteoporosis. A balanced nutrient rich diet is essential for maintaining bone density. So next, the physical activity, the regular exercise improve bone density, muscle strength, and balance, and reducing fall and fracture risks. Fall and fracture risks. Weight bearing exercises like walking, dancing is very essential for to prevent postmenopausal osteoporosis. So we should try to enjoy ourselves by dancing and other extracurricular activities. So should be done most days while resistance training like lifting weights squats 2 to 3 times weekly enhance muscle and bone strength. Balance focus activities like Tai Chi yoga help prevent fall, vital for osteoporotic patients. So number the lifestyle modification now come to lifestyle factors like healthy habits significantly impact bone health. Smoking cessation help preserve bone mass, while limiting alcohol intake lowers bone loss and fall risks. So sunlight exposure 10 to 30 minutes 3 to 5 times weekly promotes vitamin D synthesis and aiding calcium absorption. The sunlight exposure is very important. These lifestyle changes support overall bone strength and reduce osteoporosis complication. These are the lifestyle modification. And the now come to the pharmacotherapy options. Here the first line therapy. Here the bisphosphonates, aldronate or isodronate are primary treatment for osteoporosis. They inhibit bone resorption and reduce vertebral, non-vertebral, and hip fracture risks. Oral forms are taken weekly, monthly, IV forms every few months to annually. The selective estrogen receptor modulators like raloxifene mimics estrogen effect on bone, lowering vertebral fracture risks and offering protection against estrogen receptor positive breast cancer. However, they are less effective for non-vertebral and hip fractures. The hormone-based therapies are like hormone replacement therapy. HRT combines estrogen progesterone to reduce bone loss and fracture risks, particularly in symptomatic women less than 60 years of age. The long-term use is limited due to risks of stroke, breast cancer. Tibolone offers estrogenic, progesterogenic, and androgenic effect. It improves bone mineral density and reduces vertebral fracture risks with a potentially lower risk of breast endometrial effect compared to hormone replacement therapy. So for anabolic agents like teriparatide, PTH135 1 to 34, and abaloparatide PTHRP analog stimulates bone formations and are used in severe osteoporosis and bisphosphonate intolerant patients. Administered daily via injection, both reduce vertebral and non-vertebral fractures. Use is limited to 24 months. The other agents like denosumab inhibit RNKL, reducing bone resorption. Given every 6 months, it effective is reducing for pain relief in vertebral fractures, has limited efficacy and is a no longer preferred treatment due to potential cancer risks with prolonged use. Nowadays, it is not popularly used due to cancer risks. So, comparative efficacy and safety, that there are common adverse effects of bisphosphonate esophagitis, dyspepsia, abdominal pain, flu-like symptoms. There are serious and adverse effects like osteonecrosis of jaw, atypical femur fractures, and clinical considerations like avoid long-term use and remain upright after oral dosing. Some raloxifene, the common adverse effect of raloxifene, hot flushes, leg cramp, or embolism, and clinical
Actually, I think there is
vaginal
internet
bleeding.
problem. Mm.
Hello, pardon,
Yes,
sir.
ma'am. Yes, ma'am.
Okay,
Just continue and wrap up, please.
okay. So guideline and recommendation here, I skip the slide. The Indian Menopause Society uh, provides tailored guideline for the management of postmenopausal osteoporosis, addressing unique challenges such as early menopause, nutritional deficiencies, and limited healthcare access in Indian women. So I recommend early screening using DEXA scan in at high risk women, especially those with menopause before age 35, and use tool like FRAX-NS to estimate fracture risk. Lifestyle modifications, adequate calcium 1,200 milligram per day, vitamin D 800 to 1,000 international unit per day, intake regular weight bearing exercise, and avoidance of smoking and alcohol are emphasized. The pharmacological treatment is guided by severity and risk with bisphosphonate as first line agent, raloxifene for those intolerance to bisphosphonate, hormone replacement therapy for symptomatic early postmenopausal women, and teriparatide reserved for severe cases. Periodic monitoring of bone mineral density and individual therapy duration, including potential drug holiday, are advised. So these are the guidelines and recommendations of IMS. Underscores the importance of public health initiative and provide education. In contrast, the Endocrine Society and National Osteoporosis Foundation and recommend BMD testing for all women aged 65 and older and young women with risk factors along with drugs-based risk assessment. So they also advocate regular monitoring and re-evaluation therapy, even 3 to 5 years, including consideration of drug holidays for bisphosphonate uses and continuing the high-risk patient. These are the Endocrine Society guidelines. I skip the slide due to time, therefore, time duration and lack of time. And here the case study, patient's profile, 63 years, the management plan, diagnosis osteoporosis based on T-score less or equal to minus 2.5. Initial therapy, start oral bisphosphonate alternate 70 milligram weekly due to uh, high fracture risk and uh, good renal function. The case study here, the one case is supplementation, prescribed calcium, vitamin D, lifestyle modification is very essential. Monitoring is another essential factor. Repeat DEXA in 2 years and check serum calcium and vitamin D level periodically. Follow-up is very essential. Monitor adhere and reassess fracture risk annually. Consider choosing to denosumab or an anabolic agent if bone loss continues or fractures occur despite treatment.